Severe eclampsia encompasses high blood pressure of systole more than 160 and distal more than 110 on 2 occasions, and significant proteinuria. Modern definitions also include women with moderate hypertension who have at least 2 of the features below: low blood platelet count, that is less than 100 times 106 per liter, abnormal liver function, liver tenderness, hemolysis, elevated liver enzymes, and low platelet count, that's ELP syndrome. Clonus, intermittent muscular contractions and relaxations, papilloedema, gastric pain, vomiting, severe headache, visual disturbances, flashing light similar to migraine. This condition, unless treated effectively, can lead to eclampsia with risk of mortality and morbidity. The woman must be admitted to a high-risk obstetric ward for medical treatment to bring her blood pressure under control, reduce the risk of fluid overload, prevent seizures. Oral labetalol or nifedipine may be used. If the BP is less than 170/110, IV labetalol. If the BP is more than 170/110, IV labetalol or hydralazine may be given in bolus doses to lower the BP, and then as a continuous IV infusion. IV magnesium sulfate may also be administered, as this drug reduces the chance of an eclamptic seizure by 50%. Fluid restriction and a low salt diet should be initiated and monitored with a fluid balance chart, including regular urinalysis to assess proteinuria. The midwife should also be aware of the magnesium sulfate toxicity, which may be present with reduced urine output of less than 10 mL per hour. The effects on the fetus are as for preeclampsia. There is an 80-fold increase in iatrogenic pre-birth or preterm birth before 33 weeks, IUGR, consequent admission to NICU. Fulminant eclampsia. This is acute worsening of symptoms, especially headache, epigastric pain, and vomiting, accompanied by high blood pressure. It indicates that severe eclampsia is developing into eclampsia and that a conversion is imminent. Consequently, emergency intervention is required. Differential diagnosis: epilepsy, history of epilepsy, no elevated VP. So in epilepsy, then cerebral malaria and meningitis, it can be confused. So of course, somebody with epilepsy will have history of epilepsy, no elevated BP, no proteinuria, cerebral malaria, fever, blood slide positive, no proteinuria, no elevated BP, meningitis, headache, fever, stiff neck, positive lumbar puncture, no proteinuria, no elevated BP. Principles of management of eclampsia: stabilize mother or severe preeclampsia rather. Principles of management: stabilize the mother and deliver the fetus. Treat and prevent fits. Treat blood pressure, attention to fluid balance, be aware of and prevent complications. So if a patient is in eclampsia, management of a fitting or unconscious patient include calling for help. Position the patient in left lateral position. Airway open, maintain airway sanction if necessary. Recovery position, that's circulation, pulse, BP, IV access. Give magnesium sulfate 1 liter in 1 liter ingress lactate and 1 liter ingress lactate, or in 1 liter ingress lactate and normal saline in 12 hours. Do not leave the convulsing mother alone. Summon medical and senior midwifery aid together in equipment to site an IVI, administer emergency drugs, and set up bed rails. In the community, ambulance and paramedic team are required. Try to reassure the mother and her relatives. Prevent any subsequent injury to the mother with bed rails and by applying padding. So airways, protect from aspiration by placing the mother in left lateral position. Assisted by a wedge if she is still pregnant. Use suction for oral secretions. B. It's breathing. Anesthetist should be called for possible intubation. Consider an oral airway. Administer supplementary oxygen by face mask. C. Circulation. Observe the pulse, and if cardiac arrest occurs, commence continuous chest compressions. Cardiac massage. The doctor should site an IVI and take blood samples for full blood count, grouping and saving, or cross matching. Clotting factors, uric acid, LFTs, liver function tests, serum calcium, urea, and electrolytes. So prevention of convulsions will entail magnesium sulfate will have the risk of convulsions in eclampsia in women with severe pre-eclampsia. It's used in the same dose as eclampsia. There is commitment to delivered in severe eclampsia. Magnesium sulfate is a drug of choice, superior to any other drug preparation in preventing, reducing the risk of recurrence of convulsions. 20 or 50% concentration are available. 20% preferred for IV route. More dilute, but greater volume. 50% preferred for IM route, less dilute and smaller volume. So this is the magnesium sulfate dosage. Loading dose: IV 4 grams, 20% solution slowly over 15 minutes, and 10 grams, 50% IM, given as 5 grams in each buttock with 1 ml, 2% lignocaine soon after the loading dose. So it's part of the loading dose. So the first one, we can see IV 4 grams, 20% slowly over 15 minutes, together with 5 grams each buttock of the 10 gram 50% IM, together with 1 ml 2% lignocaine soon after the loading dose. Maintenance dose, that is 5 grams IM for hourly. So the management note: IV maintenance dose of 1 gram 20% per hour in every 24 hours. Per 24 hours should be applied if IV pump is available to avoid toxicity. So route IM dose 5 grams. If you have 50% solution available, vial containing 5 grams in 10 ml, that is 1 ml per 2 ml. In every 2 ml, 1 gram in every 2 ml rather. So 10 ml and 1 ml of 2% lignocaine. So it is not applicable for 20%. Then IV, the 4 gram one is we can put 8 ml if you have 50% solution available. To make it the 20%, you can put 8 ml plus 12 ml NS. So we can also see 20% will be 20 mils of solution. The 2 grams, to make it 2 grams, you can see 4 mils plus 6 mils of NS. On the other side, you can see 10 mils. So if unable to give IV, give the loading dose IM only. If conversions recur, give an additional 2 to 4 gram IV over 10 to 15 minutes. Give lower dose 2 gram if the patient is small or weight less than 70 kgs. If dilution is required for IV route, use normal saline, not lignocaine. Magnesium sulfate toxicity. Do not give the next dose of magnesium sulfate if there is an absent NEJEC, urine output less than 100 ml in the last 4 hours, respiratory rate of less than 16 breaths per minute. If respiratory rate is less than 16 breaths per minute, stop magnesium and give calcium gluconate 10%, 1 gram IV over minutes. Treating high blood pressure. Non-severe hypertension, that is BP of 140 to 159, 90 to 109, over 90 to 109. So increased risk of hemorrhagic shock. Goal, lower levels of systolic BP from 140 to 152, and the diastolic BP 90 to 100. So safe drugs include methyl-dopa, nifedipine, labetalol, and other adrenoceptor blockers, which include metoprolol, pindilol, and propranolol. Treating high blood pressures, severe hypertension rather, that is BP of more than 160 over 110, increased risk of intracerebral hemorrhage. Goal is to lower to levels of systolic BP 140 to 150, DPP, that is diastolic BP 90 to 100, at a rate of 10 to 20 every 10 to 20 minutes. So safe drugs include hydralazine, nifedipine, labetalol. Any precipitous fall in BP. Avoid precipitous fall in BP. So considerations: give nifedipine orally. Atenolol may cause fetal growth restrictions. ACE1 and 2 inhibitors are contraindicated. Avoid labetalol in severe asthmatic women. Diazoside, ketanserin, nimodipine, and magnesium sulfate should not be used to reduce BP. Sodium nitroprusside is not recommended for routine use, may cause risk of fetal cyanide toxicity and maternal paradoxical bradycardia. The nursing management, fluid management in severe preeclampsia, stroke eclampsia. Fluid restriction, you should keep them dry. Capillaries are leaky, therefore control fluid input to reduce the risk of pulmonary edema. Restrict IV fluids to 1 gram per kg per hour or 80 ml per hour. Monitor appropriately via use of appropriate monitoring chart and catheterize if necessary. delivery, assess pregnancy and assess the cervix, vaginal delivery of CS, vaginal delivery. If no maternal or fetal distress, no obstetric contraindication, and cervix is favorable, delivery should be done within 12 hours after onset of fits. Pain relief during labor can be provided by opioids or use of lumbar epidural anesthesia or analgesia. Platelet count should be equal to or less than 100 million. CS, cesarean section, if repeated fetal distress, unfavorable cervix, and any other obstetric indication should lead to CS. Stabilize the patient first. Regional anesthesia. Spinal anesthesia is preferred for CS in a pre-eclampsia. Risk for hematuria in the presence of coagulation abnormalities is very low. Platelets less than or equal to 100 million per liter. Hypotension is less common in healthy women. General anesthesia is indicated in coagulopathy, pulmonary edema, eclampsia, other cerebral edema, reduced levels of consciousness. Magnesium sulfate may be potential non-deparalyzing muscle relaxants, or may potentiate non-deparalyzing muscle relaxants. Cesarean section continued. Measures should be taken to ablate the potentially fatal hypertensive response to intubation in women with eclampsia by use of drugs such as fentanyl, that is aftendantil, magnesium sulfate, IV licnocane, esmomol. After delivery, continue with magnesium sulfate for 24 hours after delivery or after the last fit. Monitor until diuresis occurs. Magnesium sulfate does not reverse or prevent progression of the disease and is not used as an antihypertensive. Up to 44% of eclampsia occurs in the postnatal period. Do not be in a hurry to discharge home. So note 1. Pedal edema is a common symptom in normal pregnancy. There is no evidence that low salt intake will reduce pedal edema or treat preeclampsia. The use of furosemide or low-dose dopamine for management of oliguria in a woman with normal renal function is beneficial. Number 3, magnesium sulfate is excreted in breast milk but is safe for breastfed infants. So we'll cover in our next video HELLP syndrome.